안녕하십니까. 저는 필코리아 테크놀로지의 김지영이라고 합니다. 금일 웨비나는 알라마 바이오 사이언스사의 시니어 디렉터 더글라스 하이너필드 박사님을 모시게 되었습니다. 더그 박사님은 단백질 바이오마커의 조기 검출 및 정밀의학 연구를 위한 기술을 소개해 주실 예정입니다. 특히 알라마 바이오 사이언스의 아르고 HT 시스템은 누라이자 기술을 기반으로 한 완전 자동화, 고감도 단백질 정량 플랫폼으로 최대 250개의 타겟 단백질을 정밀하게 검출할 수 있는 것이 특징입니다. 오늘 더그 박사님께서는 Fully Automated Ultra Sensitive Proteomics Platform for Profiling Biofluid Samples 이라는 주제로 누라이자 기술의 원리와 장점, 워크플로우, 주요 패널 및 실제 연구 적용 사례를 발표해 주실 예정입니다. 강의가 끝난 후에는 Q&A 타임이 있을 예정입니다. Doug, please start your presentation.
All right, thank you. Pleasure to get to speak to you all today. And let's see. All right, yeah, just a little introduction to Alamar Biosciences. We were founded in 2018, spent a number of years developing the platform, the chemistry, the technology, and launched the Argo and NULISA platform early last year. Our mission is to power precision proteomics to enable the earliest detection of disease. Again, we have the NULISA chemistry, which I'll talk about. We do have the capability of developing very high affinity specific antibodies, and then the instrument itself. So, the discovery and translation of protein biomarkers to enable the earliest detection of disease, that's our mission. Biofluids provide the best non-invasive and economical method for early screening and monitoring of disease. Proteins are a direct measurement of the dynamic nature of that disease, but protein detection is very challenging, as I'm sure many of you know, mostly given the really huge dynamic range of the plasma proteome. To be sure, if you want to detect proteins that are going to be diagnostic, prognostic, serve as companion diagnostics for therapies, be useful for MRD monitoring or early detection, the technology has to be sensitive. You have to be able to detect very low abundant proteins within the circulation. So the Alamar platform, NULISA, really seeks to eliminate the trade-offs that you have with many existing approaches. So most importantly, we have sensitivity. So femtogram per mil, we consistently get that level of sensitivity across many hundreds of proteins. We can, just from a 25 microliters plasma sample, we can detect proteins that are differentially abundant in as much as 12 logs. Currently, we have panels up to about 250 plex, and the platform is very easy to use. The data is very tight because it is a fully automated platform. So we provide both kits. So these kits can be for different panels. They can be for different singleplex assays. We have the instrument itself. You load the reagents, you load your samples, you press go, it does everything for you. And then we have software for setting up experiments, processing data, and performing a QC and analysis of that data. So the instrument itself, it's really a simple workflow. It's about 30-minute hands-on time, which is really mostly pipetting your samples into the plate. For the singleplex assays, this instrument does contain a qPCR machine. So we generate a qPCR-based readout, and you'll see how that works in a few minutes. But that takes less than 8 hours. The multiplex workflow, where that qPCR machine is used to generate a sequencing library, it outputs a single library. All you have to do is take that library, quantitate it, and sequence it. So you don't have to do any library prep or library cleanup. It's high throughput, so you can run up to 258 samples across 3 plates per day. As I said, it only takes 25 microliters of sample, so very small amounts of sample. And then we have a full cloud and actually non-cloud version of our software for all of the analytics. So essentially, you're preparing your samples in the sample plate, loading it in the instrument with the reagents, and pressing go. For single-plex assays, you can get those results in as little as 8 hours. Or for multiplex, you get that single library, you then sequence it, and then perform analysis. So at the heart of this is not really the instrument, it's the chemistry. So how does that chemistry work? So, you're starting with a specific target or antigen, in this case, a protein. We have one antibody that is bound to a poly A tail and also bound to a unique molecular index. A second antibody is biotinylated and bound to a separate molecular index. We then, when those antibodies bind, those two DNA molecules come into proximity. We then add an oligonucleotide to facilitate ligation so that this then becomes a single ligated strand of DNA. So how does this work in the instrument? Everything is automated. So you load the samples of reagents, and everything that I'm going to show you happens without any human intervention. So it starts with just the formation of the immunocomplex. It then binds that complex to an oligo-DT bead via the poly A tail. It washes away the background. So here you just have some full complexes and then just some free poly A conjugated antibodies. We then release that from the oligo-DT beads. We then bind it to the other side to the streptavidin-coated beads. Again, these are magnetic beads, so everything is happening with magnets within the instrument. Again, wash away what doesn't bind, and it's this dual capture and washing that gives us the sensitivity, removes the background, gives us a sensitivity, and gives us that dynamic range. We then ligate those two proximal oligos together. And again, for the singleplex, we just amplify that. And so the more analyte you have, the more PCR product you get as measured by qPCR within the instrument. For sequencing, we amplify it and then we sequence it. And then based on these target molecular indices that indicate which antibodies abound, and a sample molecular index that indicates from which sample within the plate did that sequencing read come from, we're able to process all of that data. So, looking at singleplex assays, and this was all published last year, I'll provide the reference in a minute, comparing to standard proximity ligation, this dual capture and washing, dramatically increases the sensitivity of the assay, but also importantly, it increases the dynamic range. And then comparing same antibodies, same antigen to what has really been the gold standard for sensitive singleplex or low-plex assays, the Simoa, the Quanterix Simoa platform. We also see improved sensitivity versus that platform as well. So, we consistently see femtogram per mil level sensitivity across multiple different assays. These are two recently released singleplex assays. Our brain-derived phospho-tau217, I'm going to talk a lot more about that later. 80 femtogram per mil sensitivity. Neurofilament light, very important protein for neurodegenerative diseases. Again, about 30 femtograms per mil sensitivity. So in this case, what we did is we looked at analytes as singleplex qPCR assays, and then we looked at those same analytes using the same antibodies using our multiplex workflow. And essentially what this slide represents is that you get the same results, whether you're looking at it in a singleplex format or a multiplex format. And that really gave us the confidence to then start building out these large multiplex panels. The first one that we launched was the NULISAseq Inflammation Panel 250. You can see, a collection of really important cytokines, chemokines, growth factors. And again, these are all proteins that are very challenging to detect in normal, healthy samples with other technologies. We have an absolute quant version of that where you generate picogram per mil, absolute quantitation values for inflammatory markers. We're going to talk a lot about this panel, the NULISAseq CNS Disease Panel, really the leading panel by far for looking at plasma in the context of neurodegenerative diseases. You can see these proteins like the A beta isoforms, which form the A beta plaques, phospho-tau isoforms, which form the neurofibrillary tangles, things like alpha-synuclein, TDP-43, all very important proteins in the context of neurodegenerative disease. And for sure, inflammation is fundamental to the development of these diseases as well. We've also recently launched a mouse panel, for sure the most comprehensive mouse panel out there, focusing both on inflammatory immunology markers, neurodegenerative markers, and oncology. So you can build these great panels with all the best proteins and all the best antibodies, but if you can't detect them, it's not much good. What this shows, this is each one of these bars is an individual analyte in the panel. This is the LOD for those analytes. And essentially what this shows is that 99.6% of all the targets in the panel were detectable in at least 50% of the samples. So that's how we sort of measure detectability. And these are just healthy, normal plasma samples. These are not samples from diseased patients. So, with that ability, you can see both increases in these and decreases in these proteins with disease. We also have a small collection, but growing, of single-plex assays, IL-4, again, neurofilament light, and brain-derived p-tau217, and we'll continue to expand the production of these single-plex assays. You can read more about NULISA in this publication here. So kind of focusing first on Alzheimer's disease, which has really been the area where I think there's been the fastest and most significant impact of the NULISA platform. So these are all really leading researchers in the space of biomarker discovery in neurodegenerative diseases. And they all have sort of different areas of focus around identifying biomarkers for neurodegenerative disease. And I'll talk about some of that here in just a moment. So starting with really a key foundational study for us, this was called the Round Robin Study. And essentially what this is a collection of well-curated CSF and plasma samples from both Alzheimer's disease patients and non-patients. And they take these samples and they send them out across the world to different labs running different technologies, different labs running the same technology, just to understand the performance of these platforms and the consistency of these platforms for detecting key markers of neurodegeneration. So looking at the NULISA data from that, one of the things we did with those samples is we ran both the NULISAseq and the NULISA qPCR assay, so both singleplex and p-tau217 in the context of the multiplex assay, and we see that we get the same results, whether you're using singleplex or multiplex. This is looking at both CSF and plasma, but if you break it out by just the CSF or plasma, you see very high correlations. If you then look at the ability to detect changes in these key phospho-tau markers between the non-AD and the AD, here we have the NULISA singleplex for phospho-tau217 and the NULISA multiplex for phospho-tau217, both showing very strong differential analysis in plasma, which is very important, and then in CSF, the singleplex and the multiplex. So just an initial sort of important publication just showing that this NULISA platform works well and works comparable to other platforms in detecting these proteins. So this was a case study by Mara Malpetti in Cambridge, and she's looking at novel blood-based proteomic signatures across multiple neurodegenerative diseases. So, the current clinically used Alzheimer's test really, by and large, includes CSF measurements of A beta 40 and 42, phosphorylated tau, and amyloid and tau PET scans. So both CSF measurements, which require a lumbar puncture, or PET scan, have high cost, infrastructure, and patient tolerance to both of these is actually quite challenging. There's also methods for differential diagnosis called a seed amplification assay, using biofluids and skin biopsies. But again, there's issues of co-pathologies, and it's very difficult to scale. So Mara's hypothesis was blood-based proteomic biomarkers can be utilized for early and accurate differential diagnosis of neurodegenerative diseases. Because it's blood, it's scalable in routine clinical care. Blood-based proteomic biomarkers have the potential to define therapeutic targets and confounding factors, and blood biomarker signals can potentially reflect clinical and pathological heterogeneity within and between the diagnostic groups. So these were the four diseases that she interrogated. And I think one of the key features is cognitive decline is a part of all of these. So if someone comes into a clinic, has issues with cognitive decline, you can't immediately say, do they have Alzheimer's, Lewy body dementia, FTD, or PSP? But, as you may be aware, there are, I think we're making a lot of great progress in actually having treatments, both therapeutic and sort of lifestyle interventions that can help stave off or hopefully one day prevent these diseases. But if someone has just cognitive decline, you really need to know what is the disease they have so that you can start a treatment before it gets too significant. So in her study, she had plasma samples from these different diseases. You can see the number of samples here. She did both the NULISAseq CNS panel and the NULISAseq Inflammation Panel. As is, you'll see, like you saw in previous studies, but as you'll see in the next two studies, the first thing people often do is they compare the results between NULISA and what has been the gold standard, the Simoa assay. So you'll see that here. She then sort of interrogated the data to find disease-specific biomarkers. So, like I just said, she first compared NULISA to Simoa, Quanterix, and saw overall very good correlation for these key markers, the phospho-taus, NFL, and GFAP. She then looked at those proteins across the different diseases, again, showing unique patterns of how they're expressed across the different diseases, as you would expect. She then started doing differential analysis, comparing controls to AD or minimal cognitive impairment, which is an early phase of AD, controls versus Lewy body, controls versus PSP, and controls versus FTD with the CNS Disease Panel and the Inflammation Panel. And so, what jumps out from this and what's really nice is you see sort of the classical phospho-tau markers that are expected in these diseases. You see NFL, so you don't see the phospho-taus in PSP or FTD. You do see NFL as the most prominent marker, indicating a high level of neurodegeneration. So again, you see pretty clearly the ability to start to differentially diagnose these diseases using plasma. Then looking at the inflammation panel here for AD, you see GFAP, but you see a very different collection of markers for these different diseases. So it's really a great result to start to be able to parse out these diseases. She then looked across all of the diseases and assessed whether there are proteins from these panels that can actually predict survival. So, for example, with NFL, high levels of NFL are deleterious. Low levels of NFL predict further survival. CRH, high levels of it are actually have better survival. Low levels have worse survival. And then also from the inflammation panel, just an example with CD276. So not just differential diagnosis, but also, giving some indication about their survival impacts of these different diseases. So this sort of summarizes it all here. I don't need to go through all of this, but I think just highlighting the NULISA CNS and inflammation panels identify disease-specific patterns in neurodegeneration and neuroinflammation, offering insights into disease-specific pathologies. So that's from the conclusions of the publication. So in those cases, people already had clinical manifestation of the disease. So they all came in with cognitive decline, or they all had, were essentially had the disease. In this case, we're looking at people that don't yet have any clinical manifestation of the diseases to see how well the panels can predict the occurrence of the disease itself. So in this study by Dr. Carey, he was really interested in inflammation, vascular, and synaptic biomarkers in plasma specifically. So the goal is to evaluate technical performance and diagnostic accuracy of blood-based biomarker profiling with the CNS panel specifically. His cohort was 176 plasma samples from 113 cognitively normal patients above the age of 65. And these were collected both at baseline and a 2-year follow-up. So he analyzed the plasma samples with the CNS disease panel, as I said, but he also did it, as we've been talking about, with Simoa to compare and really assess the performance. So key takeaway, the CNS panel enables integrated analysis of a diverse set of 80 biomarkers in plasma for more accurate diagnostic and prognostic applications. So again, comparing to the Simoa results, both looking at correlations, but also looking at AUC or sensitivity and specificity for predicting amyloid PET positivity. So just a little background on that. Diagnosis. So if you have amyloid PET positivity of the brain or tau PET positivity of the brain, those things are essentially diagnostic on their own of Alzheimer's disease. So what you're asking here is, how well do these markers predict whether or not you're going to go on to get amyloid PET positivity? So again, showing overall pretty comparable results with the Simoa. But again, Simoa can look at 1, 2, 3 proteins at a time. We're doing this in the context of hundreds of proteins. So looking at patients that are either amyloid negative or amyloid positive, shown here, and doing differential analysis. Remember, these people already have pathology in the brain, but they don't yet have any clinical manifestation of the disease, so they're effectively normal. You can see in the higher amyloid positive, you see changes, but you see a lot of changes in the amyloid sort of negative samples. So that's just a cross-sectional. But then if you look at the amyloid negative or the amyloid positive and ask, how much do the proteins change over that from the starting point to the 2-year follow-up? You see that FGF2, for example, increases 9.1%, greater increase in the positives than in the negatives. IL-9, 15% more increase in the amyloid positive versus the amyloid negative, and then IL-4. So we sort of took a similar approach with the tau pathology here, showing the phospho-taus increasing both at baseline and at the 2-year time, and then looking at the change over time, sees these increases as well and decreases. And then looking at neurodegeneration itself. I think one thing that's notable is it's a pretty unique set of markers that are identifying these different types of pathologies. So overall, the NULISAseq demonstrated strong correlation and comparability with the Simoa assay, so good to start there. Plasma, p-tau217, 231, and GFAP all show diagnostic accuracy for A-beta or amyloid PET. Here, the phospho-tau markers, not surprising, show high performance for predicting the tau PET. And then, he looked at a variety of other markers, and as you saw, identified a variety of other markers that show both cross-sectional and longitudinal associations. So the translation of these prior findings in CSF, so again, initially looking at CSF, much more difficult to obtain. But comparing those to plasma indicates that the molecular processes in AD involving these biomarkers are reflected in the bloodstream, expanding the repertoire of blood-based indicators of brain pathophysiological changes. So all those experiments, we talked about p-tau217 and p-tau181 and so forth, but we didn't talk about the brain-specific forms of that. And this is a more recent, very recent sort of discovery and something that we've recently added to our panels. So tau protein distribution. So in CSF, cerebrospinal fluid, 100% of the tau comes from the brain. But when you look in blood, tau comes from the brain and the periphery. So only estimated about 20% actually comes from the brain. The rest is coming from peripheral nerves and peripheral organs. Yet most assays with blood do not differentiate that. So looking at tau, there is what we'll call the total tau form. So that's looking with an antibody to the N-terminus and then to an antibody to the specific phosphorylation modification. Excuse me. The brain-derived tau also has this same N-terminal region, but it has a unique splicing junction that does not exist in the total tau. So we can tell with this assay if it is brain-derived tau. It's specific to it. While this assay detects the total tau, but it also detects, because we have this region, the brain-derived tau. So it can't differentiate the two. So in plasma, the BD assay shows higher correlation with CSF measurements. So if you look at plasma in CSF with the total tau, in CSF, it's only brain-derived tau. In plasma, it's both. So the correlation's not very good. But if you use the brain-derived tau, now in CSF, it's only brain-derived. In plasma, you're only looking at the brain-derived. So it's a very high correlation. And that's what we would expect to see if the assays are working as we design them. So in CSF, brain-derived 217 demonstrates high correlation to total p-tau217. In plasma, the correlation between the two configurations is lower. So again, when you take the p-tau217, the total p-tau217 versus the brain-derived in CSF, it's very high because it's all you're looking at. There is no peripherally derived tau. But in plasma, when you do that correlation, again, it's not as strong of a correlation. So what are the clinical implications of this? So we actually looked at it from the perspective of both Alzheimer's disease, which is a brain-derived disease, versus ALS, which is a peripheral-derived disease. So in Alzheimer's disease, elevated p-tau217 in the brain is a hallmark of disease and the major disease biomarker for diagnostics. For ALS, p-tau217 is elevated in blood, but not brain, and it's associated with ALS development. So detecting, the clinical side of this is detecting brain-derived p-tau217 can provide better sensitivity and specificity for early diagnosis of Alzheimer's because you're looking at the form of p-tau that really matters. Versus detecting brain-specific and total p-tau217 can distinguish ALS from AD, as you'll see. So in AD, both total and brain-derived tau assays show similar degree of elevation in CSF. So you're looking in CSF, and essentially you're seeing a similar result between the p-taus and the brain-derived taus. And again, the reason is because they're both looking at the brain-derived taus. They're looking at the same thing. Brain-derived tau shows much larger separation in plasma, though. So in this case, you're looking at right. So sorry, right here, when you look at the plasma AD versus control, the brain-derived tau versus the total tau, you see a much bigger difference in the brain-derived tau. So it is a more sensitive assay, and it shows a larger difference. And that's because, again, you're looking at blood, but you're really interested in what's coming from the brain. So if you look at it from the perspective of area under the curve, or predicting essentially disease onset, if you look in the CSF, again, the phospho-tau, total phospho-tau, and the brain-derived phospho-tau gives you the same result because you're only looking at the brain-derived measurements. But in the blood, you get a much better AUC when you look at just the brain-derived tau, because you're really focusing again on the form of tau that matters in the context of that disease. So this difference is what really shows the value clinically of the brain-derived isoform of it. Importantly, we look at both in our panel. So it has applications for Alzheimer's disease, but it also has applications for things like ALS, MS, and other diseases. So evidence that phospho-taus are higher in ALS blood, but not brain. So this is previously published data showing phospho-tau 181 control asymptomatic and then ALS, and 217 control asymptomatic in ALS. So in ALS, CSF, both configurations of tau show similar trend, some mild increases in ALS. So, essentially, both tau assays show only slight elevation in CSF. it's a peripheral disease. You wouldn't expect much. But when you look at blood, you see the regular phosphotals show a very big difference, while the brain-derived tals don't. Again, this is as expected because the brain-derived tau, you shouldn't be detecting changes in that in ALS. So great assay for more sensitive detection of Alzheimer's disease, great assay for sort of differential diagnosis as well. So shifting gears to the inflammation panel, just one sort of case study, a recent publication I wanted to highlight. So in this publication by Dr. Jamie Lin at MD Anderson, she's looking at identification of biomarkers of immunotherapy-induced kidney toxicity. So the current state, up to 20% of immune checkpoint inhibitor-treated patients develop acute kidney injury. Of these, 2 to 5% have acute interstitial nephritis, which is an inflammatory renal lesion. So glucocorticoid therapy achieves 40% full response for immune checkpoint inhibitor AIN, but other types of acute kidney disease require other treatments. Kidney biopsy is the gold standard for determining which type of kidney disease is occurring. And so having a non-invasive biomarker would reduce morbidity risk and improve patient management. So essentially, you're monitoring patients that are on immune checkpoint inhibitor for kidney function because that's a toxicity from it. You're seeing people with acute kidney injury. Now you have to figure out what type of injury do they have in order to determine which therapies will work. So rather than doing a biopsy, it would be nice to be able to have a non-invasive test. So while previous proteomic studies have revealed some candidate biomarkers, it's hypothesized that a more sensitive analysis would reveal better and more predictive candidates in urine and or plasma. So again, this is showing the different, you can look at the key here, the different types of immunotherapies, and these different immunotherapies can cause a variety of different kidney toxicities. So in this study, she had 22 patients. Everybody had immune checkpoint inhibitor therapy. Some had acute interstitial nephritis, AIN, some did not. She analyzed both plasma and urine using the inflammation panel. So first off, if you look at the differentially expressed genes, which are highlighted here, the first thing you see is that in plasma, there's a very small fold change in those. But in urine, there's a much greater fold change between those with AIN and those without AIN. Then if you look at it at a pathway level and looking for pathways that are differentially expressed in the context of either the urine or the plasma, another thing you'll see is, again, a lot more proteins that are being identified as being differentially expressed and influencing these pathways. But also, most importantly, the p-values are dramatically different. So again, much more significant changes in the urine than in the plasma. Maybe not a surprise, given that this is a kidney disease. They then identify 10 proteins that have very high distinction between the ICI-AIN and non-AIN in the urine. And you can see those 10 proteins start to do a pretty good job of separating the two patient types. They then use some sort of machine learning type algorithms, and again, identify a set of markers that are best selected for in terms of distinguishing these two types of response. And I think most importantly, if you look at the AUC for predicting this, actually CXCL9 was previously known to be a marker that could predict this, but what you see is, they discovered IL-5 and FAST. If you build a signature of the 3 of these, it outperforms any of these alone. So, this study sort of added to the existing knowledge on CXCL9, added 2 additional markers, and then, again, a signature involving those 3 really gives the best clinical predictability. So, in conclusion, they do determine urine is certainly a better matrix type for distinguishing the kidney pathology. So really great study, great application, not of immune checkpoint inhibition in cancer therapy itself, but important toxicities related to that. So shifting gears to the mouse panel, again, this is a panel that contains a lot of immunology-focused markers, a lot of the key neurobiology markers, again, phosphotals, alpha-synuclein, TDP-43, and oncology markers as well. Most of the studies we've actually seen have been in the neurology space, but there was just a paper published very recently that looked at something that's very important in this day and age, which is GLP-1 receptor agonists. Originally approved for type 2 diabetes. Of course, we all know it's used widely for obesity as well, but it has a lot of effects. Blood vessels, pancreatic islet cells, gastrointestinal tract, and CNS impacts. So the application of these GLP-1 receptor agonists to different disease types is really potentially quite remarkable and important to study. So in this case, they actually used a rat murine model with the mouse panel. And so the current state with regard to this publication by Dr. David Leffer at Cedars-Sinai in LA, GLP-1 receptor agonists are showing therapeutic benefit beyond diabetes management and weight loss. His interest is heart failure. So heart failure with preserved ejection fraction is the most common form with limited treatment options before these GLP-1 receptor agonists. So 80% of these heart failure patients are obese or overweight. GLP-1 receptor agonist treatment is effective, but it strongly correlates with substantial patient weight loss. So the question that he has is, can GLP-1 receptor agonists be used to treat heart failure and not induce significant weight loss? Why is that important? I mean, for people that are obese, the fact that you're giving them these drugs and they're improving their heart function is great. But what about people that have heart disease and are older, maybe not overweight? You don't want them to lose their appetite. You don't want them to eat less. So you would like to be able to see, can I lower the dose of these receptor agonists, have an impact on the heart without impacting essentially their diet or how much they eat. So that's really the goal of this study. So the first thing is, can they get to a dose where they don't see changes in the weight of the rat? So measuring body mass, no difference in body weight between controls and treatment at this dose that they identified. So that's a start. That was sort of a critical piece for the study. And then they looked between the treated and the vehicle at 2D echocardiogram, exercise stress test, and invasive hemodynamics. And essentially what they see is improve exercise capabilities, changes in the echocardiogram, and reduced lipid production. So it seems to be having the effect that they wanted to be having without the weight loss. Again, that was really their critical goal. They also did some single-cell RNA sequencing to look at the hepatic transcriptome and so forth. But looking specifically at using NULISA, here they have obese rats, either treated vehicle or GLP-1 receptor agonists, and they did the mouse panel and then looked for proteins that were differentially expressed between the two groups. So looking at the most differentially expressed proteins, again, they can clearly distinguish using the mouse panel between those that have been given the treatment versus vehicle. They then look at, what are the proteins that are differentially expressed between the two, shown both in a heat map version and a volcano plot and scatter plot. But essentially, they did identify some really interesting proteins. So here's a protein involved with coronary artery calcification and vascular dysfunction, monocytes and linked to systolic dysfunction, TRIM2, increase in lipid association macrophages that drives atherosclerosis and so forth. So really interesting application of the mouse panel in a disease area or a therapeutic area also that is of extremely high interest in this day and age. So, we've looked at essentially serum, plasma, CSF the whole time. You can also use these panels, and we continue to grow this list as we get more experience with customers around the world. You can look at saliva, nasal fluid, urine, as we saw, tissue lysates, non-human primates. The human panels do really well in HPs. With the mouse, we've looked at a variety of lysates. We've even looked at CSF, which is a really small amount of sample. In fact, one of the nice things about the mouse panel is it's so sensitive that even if you have very small amounts of material and you have to dilute it before analyzing it, you're still going to get excellent results. So we continue to expand this. If you have an interest in different sample types, different tissue types, for any of the panels, that's something, we can talk about. Dried blood spots. So this is an area that's gotten a lot of attention. It's always had a lot of attention, but I think that attention is really growing. And it's been really important in the context of dementia and neurodegeneration, where the notion that you can have people sort of collect samples at home and then send these cards off for biomarker analysis would have a great deal of value in terms of monitoring patients both on disease or therapeutic interventions, lifestyle interventions to see how they're progressing or if it's slowing different biomarkers of the disease. What this is simply showing is that using the dried blood spot, we continue to get very good sensitivity for very important markers like phospho-tau217 and so forth. And if we compare whole blood versus the dried blood spot, either with, this is a technology called Capitainer, but essentially the telemune cards, which we like a lot, show similar results. And it just shows you get very good correlations between the blood or the dried blood spot. So it seems to be a really good tool and strategy for collecting blood kind of coming out from the broader community into clinical labs. Just last thing, so this has all been about kits that we make available, but you can also develop your own assays. So we have a kit that allows you to develop an assay using antibodies against your protein of interest, where you can take advantage of that sensitivity and dynamic range and just overall quality of the data. So that is now available as well. And with that, thank you for your attention, and I'm happy to take any questions.